a way on checklist, right? So if the ejection fraction of the patient is more than 50, they are probably low risk. If it's between 40 and 49, they are moderate risk. If it's more than less than 40, it's high risk. One more thing about the clinical symptoms: if the patient are having any, I would say, cardiovascular instability, like arrhythmias, sudden drop in the blood pressure, sudden drop in the heart rate during the exercise, all of that sort of things is meaning that the patient is at high risk. Well, if the patient is not having any complications, like uncomplicated MI, absence of any complicated arrhythmias or anything like that, absence of chronic heart disease, all of that can be categorized as low risk, right? Let's jump immediately to that. Yeah, one more thing to consider whenever you are prescribing the exercise for the cardiac rehab. There should be warm-up, there should be cool-down. How long the warm-up should be?
15 minutes.
15 minutes. The cool-down? 10 minutes. Excellent. Right? Ignore all of that. Yeah. Yeah. Right. With every single cardiac disease, we should, especially if we are, I would say any cardiac disease. The FIT principle should be used in the exercise prescription. So let's start with the frequency. How frequent the exercise should be done? Is that the aerobic exercise that you are speaking about? Okay, so 3 to 5 times per week according to guidelines, and you have to support your choices again with the relevant guidelines. So you can say 3 to 5 times according to ESC guidelines, because that number is fitting with the ESC guidelines. Right? What about the resistance training? How frequent something like that should be?
1 to 2 times per week.
Once, 2 times?
Yeah, probably.
Yeah, 2 to 3 times. It's not one to 2. It's 2 to 3 times, okay, according to the guidelines again. It's either BACPR, it's ESC, it's all right. But ideally, it should be 2 to 3 times, right? That's all right. Yeah. So that means the exercise should be combined option. And this is one of the FIT principle, which is the type of exercise, the last one, T. So the T is standing for the type of exercise. It should be combined aerobic and resistance training. Right. What about the intensity? And I think this is the one that you're speaking about.
Yes.
Yeah, I think so. Yeah. What about the intensity of the exercise? Ideally, the intensity of the exercise should be based on the heart rate calculations. Right. Let's assume that this patient is 50 years. 50 years is right. Okay. If the patient is 50 years, then all of that is not fitting with the patient. So then we are using a kind of different way to get the training heart rate of the patient. We are usually using in the clinical practice either Ember or Tanaka. Let's assume that the patient is 50 years. Right now, try to calculate the maximum heart rate of the patient. According to Tanaka, for example. So it's 208 minus 0.7, multiply that by 50. This is going to be giving you the maximal heart rate. And when I say maximal heart rate, that means it is the maximum heart rate that can be achieved by the patient with any exercise. But this is not what we really need. We are not in need to push the patient that way. So ideally, we are just taking some percentage from that and putting that in the Darwinian formula. Let's assume that the patient is 50 years, as we mentioned. Do the calculations first to know what's the maximum heart rate based on time, for example. What's going to be the maximum heart rate for the patient? But do some calculations for that.
What's the heart rate?
So 208 minus 0.7 times 50, what's that?
220 minus. What's that? How is it 220 minus their age? 220. Well, that's what I'm going off. But why? What's it saying? It's saying 208. It's different, isn't it?
So 0.7 times 50 times 35 to 100. 8 minus 35. it's 173, right? How something like that might be different if I'm speaking about the same patient and I'll just ask you to do 220 minus age. How something like that might be different? If I put 220 minus age minus 50, then the heart rate for that patient is going to be what? 170. So that means it's underestimating the actual abilities of the patient, isn't it? That's why we are having one formula for under 45 and another formula for above 45. Right? Okay? Does that make sense? That number right now, the 173 that I mentioned, is the maximum heart rate. So the maximum heart rate minus resting heart rate equal what? Equal heart rate reserve. So let's assume that the resting heart rate for that patient was like 80. And that one, we agreed it's 173 right now. So 173 minus 80 equal 93, isn't that? Okay? 93 should be multiplied by the range of the acceptable intensity, which is like 40 to 60% according to phase 2 cardiac rehab. If you are speaking about phase 2 cardiac rehab, it should be between 40 to 60%. Okay? So you should be multiplying this 93 times 40% plus resting heart rate, which was 80. After doing all of that, you're going to be able to know what is the target heart rate.
23.
It should be around 118 for that patient. Okay? That means if the resting heart rate for that patient is 80, it is absolutely fine to be trained or to do some sort of activity up to the level of 118 beats per minute. At this point, when the patient reaches this point, I should be asking them to start the cool down phase. Does that make sense right now? Easier? Okay? Okay.
And then for the, sorry, Hadi, for the 0.7, that's the other number, and you can only go in between those ranges, but for starting off, you'd want to go to 180.
Absolutely. Yeah. So if the patient is under 45, we are just using 220 minus age to get that number. If the patient is above 45, we are using the other formulas. But by the end of the day, you should be relying on the constant formula, which is that one. Okay? So that was for the intensity of the aerobic exercise. All of that is just for the aerobic exercise. What about the intensity of the resistance training? How you can quantify that? What's that, sorry? Yeah, what's the percentage of what that? 30, 40, 50, 60%? What do you think? Of the one repetition maximum, what's the percentage? What do you think? Is that 30, 40, 50, 60, 70, 80? So it should be between 30 to 60%, okay? It should be between 30 to 60% of the one repetition maximum. If you are speaking about the cardiovascular population, we are usually starting, especially if they are having multiple comorbidities, we are usually starting with 30%, and then with every single progression, we are increasing that to be 40, 50, 60%, okay, of the one repetition maximum. Right, so we know right now the frequency for the aerobic exercise should be between 3 to 5 times. Resistance training should be between 2 to 3 times. Right. Would you be happy to do one session of aerobic and resistance training, or it's much better to separate them into different days?
Separate them into different days.
Right. If we have like a patient who is doing, based on the guidelines, 5 days of aerobic exercise and 3 days of resistance training, so it's like 8 days within the 7-day week. How to do that? Is that possible? It's not possible anyway. So at some point, you should be mixing them together, right? Okay. So that was for the frequency: 3 to 5 aerobic, 2 to 3 resistance. Intensity based on the Cartman formula for the aerobic exercise. Start with 40 to 60%. For the resistance training, it should be based on one repetition maximum. Sorry, so 30 to 60%. The type of the exercise should be aerobic and resistance, as we mentioned. the time of the exercise. What is the time of the exercise? We agreed that the warm-up should be 15 minutes, cool down should be 10 minutes. What about the stimulus phase for the aerobic exercise? 20 to 60 minutes for the aerobic exercise. What about the resistance exercise? I mean, the duration of it. Yeah, so let's say, yeah, so that means that we are doing that in the form of circuit weight training. Is that what you mean? When I say circuit weight training, that we are engaging multiple muscles. Yeah, I think, yeah, this is, this is what you would say. Yeah, so it's literally done this way in the form of circuit weight training, so multiple engagement of upper and lower limb exercise. How many muscle groups should at least we start with? How many muscle groups? 8, right? Every single one of them should be trained for 1 minute and 1 minute rest. So the least duration should be 16 minutes. Okay? So 15 warm up, 16 stimulus, 10 cool down, and this is the least amount that can be used. Yeah?
So you say 8 muscle groups?
8 muscle groups. Yeah.
Is that just for upper body?
Yeah? No, upper and lower body.
Also combined?
Yeah, combined. Yeah.
Right, so you would do like 8
8.
exercises?
Yeah, and when I say like the right biceps, this is just one. So right and left are 2.
Oh, God.
Okay?
Okay. So my right, so both biceps, that's 2 muscle groups.
We are usually not doing that, and this is this is a really good question, by the way.
Yeah.
We are not usually doing that. Ideally, we are just engaging one muscle group to avoid fatigue. So 1 by 1. So we are not doing bilateral biceps curl, for example.
Yeah.
We are doing right and left.
And that's 2.
2. That's it. Is that easy right now?
Yeah.
Okay. Good. Yeah, so this is a recommendation that we just mentioned. This is the ESC minimum recommendation for the implementation of resistance training. This is what we mentioned about the 30 to 60%. Okay, so it's based on the ESC guidelines. Yeah, let's say if in the clinical picture anything was mentioned about the balance of the patient, if they are not having proper balance, and I think Sam went through that ideally the exercise should be done from which position? Is that standing or sitting? Standing. Yeah, excellent. What if the patient is not able to stand for a while for any reason? They might be losing their balance, any other reasons. The only other option is to ask them to sit down, right? How something like that might be risky for the cardiovascular population. There might be some potential for something which is called pooling. Did you hear about that previously? So it's like a kind of stagnation of the blood in the lower limbs. So it's affecting the preload, affecting the cardiac output, affecting the afterload, and all of that. So ideally, if they are seated, they should be moving their feet at least. Okay? And that might be avoiding the option of the postural hypotension. So to avoid the option of the postural hypotension, because it's really common between the cardiovascular population, that they might have postural hypotension immediately after the session. To avoid that, keep their legs moving. That's it. Okay. What else? I think we covered everything for the fit principle for the project we have. I think so. Yeah. Any questions on that? So you know right now what is the optimal frequency, how to calculate the intensity, what are the expected types of the exercise, and what is the duration of every single exercise.
Okay, which guidelines are these based on?
It's usually ESC guidelines. ESC, European Society of Cardiology. But you can rely on BACPR as well. It's very close.
Okay.
Right? Any questions? Good. Right. Think about the cardiac you have. What are the outcome measures that should be used? 6-minute walk test is one of them. Yeah. What else? Rating of perceived exertion. Yeah. Right. So if I'm doing some quantification of the exercise intensity, we previously mentioned that it's usually based on the heart rate calculations. But what if the patient is taking any beta blockers? Would that be still valid?
No.
It shouldn't be, yeah, because the patient is, I mean, the beta blockers is changing the normal response of the heart to the exercise. But what they do actually in the clinical practice is that they are just subtracting the number that you got. They are taking out 30 of them. So let's say if the target heart rate for the patient is like 118, so if the patient is on beta blockers, I will take 30 out of that. So it should be like
88?
88. Yeah. Does that make sense?
Yeah.
Yeah. This is usually what's happening in the clinical practice. So if you know that the patient is on beta blockers, we are still relying on the heart rate measurements. However, we are just subtracting 30 from the number that we have got from the equation. One more thing, ideally, with the heart rate monitoring, if the patient is again on beta blocker, we should be relying on the rate of perceived exertion on top of the heart rate calculations. Especially if the patient is on beta blockers, we know that this might be, in a way, not very accurate. So to prevent, any potential hazard for the patient, ideally you should be relying on the heart rate calculations with the rating of perceived exertion. Right. So yeah, back to the outcome measures. We mentioned the rating of perceived exertion, 6-minute walk test. What else? If we are having enough equipment for that, ideally, what is the best thing to be used?
Looking at their heart rate.
Heart rate.
Yeah.
Heart rate is definitely one of the things. Yeah. I think you are speaking about the resting heart rate, isn't it? Yeah, resting heart rate is one of the things. But I mean, 6-minute walk test is assessing which outcome?
Oxygen levels on top of it.
What's that?
Oxygen.
Oxygen
level in the body.
utilization, yeah. So it's like the maximum oxygen uptake, isn't it? How to better assess something like that?
SATs.
SATs, VO2 max testing, CPAT testing. We are not doing any VO2 max for cardiac patients because it's in a way asking the patient to be pushed to the max. This is not what we are doing with the cardiac patients. We are just doing sub-maximal testing. Sub-maximal testing means that we are just getting VO2 peak, not VO2 max. Okay?
What's the difference?
Yeah, VO2 peak, it's technically it's like 85% of the VO2 max. So when the patient reach 85% of the predicted VO2 max, the device is just giving alarm to say that this is the maximum.
Would we be asked to calculate the VO2 max?
It's not calculated. It's something that you can get directly from the device if you are doing that test. Right?
The machine calculator.
Yeah, the machine calculated itself. Yeah, it's giving you like something which is called breath by breath. Every single breath is triggering some sort of VO2 max, and after that, all of that is put in Excel sheet. You get the mean and median for that. Yeah, and that's it. Right? Okay. We spoke about outcome measures. Any other thing? Yeah, incremental shuttle walk test can be used, for example. Okay, if this is the way that you are doing in the cardiac lab services. Yeah, that's it. So I think with the cardiac you have, that should be all right.
Yeah, because you don't use that for a pulmonary.
Is that clear for you right now? How to do the exercise prescription?
Yeah.
Right? How something like that might be slightly different with the pulmonary rehab? What do you think, guys? How something like that might be slightly different with the pulmonary rehab?
Like what?
Again, in terms of the third principle, like frequency, intensity, time, and time. Frequency. How frequent should we do the exercise in the pulmonary rehab?
So is it about incorporating into daily life as much as you can rather than balanced intensity?
Absolutely right. Absolutely right. So it's in a way 7 days per week.
Max, but little and often.
Brilliant. What about the, but I presume you are speaking about the aerobic exercise, aren't you?
Yeah.
Yeah?
Sure.
Right? Yeah. What about the resistance exercise? Shall we do any resistance training for?
Yeah.
Absolutely. How frequent something like that should be?
1 to 2 times per week.
2 to 3.
2 to 3. It's literally the same. 2 to 3 times. Okay, so it's no big difference there. What about the intensity? How to quantify the intensity? Are you still happy to use the heart rate measurements and all of that?
Is it going to 30% though, heart rate reserve, if their fastest decondition?
I would say it can be used, but this is not the best way to do it. It can be used if you are considering the cardiac element within the respiratory disease, because it's really common, especially if you are speaking about, let's say, someone with recurrent exacerbations of COPD. At some point, we are expecting that something like that should be affecting the heart, right?
Yeah.
So yeah, relying on heart rate measurements should be all right, but ideally we should be more relying on the dyspnea scores, rate of perceived exertion, and all of that sort of things. Okay, ideally that should be the case, because this is the chef complaint. This is the main problem for the patient. It's slightly different in comparison with the heart rate calculations, right? Yeah, intensity, time. What about the time?
5 to 10 minutes building up.
You mean the stimulus phase? I was speaking about the stimulus phase, I think so.
Yeah.
Yeah, it's in a way, you can start with the baseline of the patient, whatever what it is. It might be 5 minutes, it might be 10 minutes, and you can build on that. Okay? So, especially if we are speaking about the really challenging cases, something like the peripheral arterial disease, pulmonary arterial hypertension, something like interstitial lung disease. Yeah. Can you see that one? It's the next one. Yeah. So that one is giving you some exercise prescription, let's say for lung cancer, right? And you can see that it's definitely 5 to 7 days per week, right? And it can be like 30 minutes for the whole thing. If you are doing the warm up and cool down, and they are like 25 minutes, so that means that the stimulus phase can be 5 minutes, as you mentioned. Yeah, that's right. Right. What about the type of the exercise? Would you be happy to go for the with most of the respiratory patients? Would you be happy to go with the interval option or the continuous option?
Interval.
Yeah. Why?
Didn't really think that far ahead. Because it's less, because it gives them time to recover.
Yeah.
In between bounces.
Yeah, that's it.
Exercise.
Well done. That's it. But is there any evidence which is supporting the efficacy of the interval training in comparison with the continuous training? I mean, do you think that the interval should be more effective in comparison with the continuous one, for example? Yes. Okay. Right. So yeah, I would say most of the evidence is supporting that. But recently, the evidence is saying that it's absolutely fine. Both of them are the same, right? It's according to the patient preference, according to the patient ability. If the patient is able and accepting that, you can use any of them, because in terms of the efficacy, both of them should be the same. Right. What else? So we went through the time, yeah, all of that. Outcome measures. What are the outcome measures that should be used for the pulmonary rehab?
Borg scale.
What's that?
The Borg scale.
Borg scale, excellent. Yeah. MRC scale, like dyspnea score. Yeah. What else?
Incremental shuttle walk.
You can do that, but I think it's more cardiac specific. I mean, how we usually monitor the sets. Yeah. Excellent. Sets. Yeah. What else? ABGs. Yeah. That's it. Try to be focused on the pulmonary stuff, right? And this is mainly the main difference between them. That's it. I think that's it for the cardiac and pulmonary rehab. One more thing about the respiratory failure. before shifting to that one, do you have any questions with the cardiac pulmonary rehab? Is that clear? Good. Yeah. Right. So what we are expecting from you with the assessment, that you should be talking about the FIT principle, the outcome measures, how something like that is justified and supported by evidence. That's it. Right. So for those things, do you have any questions?
Andy, would our practical tasks then more than likely be showing a model like an exercise to do, like based on those principles? Then?
Not really. You're going to be more doing some sort of exercise prescription. So specifying for your model how frequent they should be doing exercise, what going to be the sort of exercise that you should be doing, all of that sort of
So
stuff.
maybe like education. to the
Education,
patient.
yeah, absolutely right. Yeah. Right. So with that, are you right? Good. One more thing about the respiratory failure. Yeah. First thing, how the respiratory failure can be ruled out that this is respiratory failure. How we can know that? Based on ABGs. Yeah. So for type 1 respiratory failure, it's usually managed by
Oxygen therapy.
NIH, the CISA.
yeah. So it's usually managed by oxygen, then CPAP, right? And type 2 is usually managed by BiPAP, which is NIV. Yeah. Right. Okay. Think about a patient with a need for oxygen therapy. Why do you think that this patient is in need for oxygen therapy? What can be the sort of finding that you should be finding on the ABG?
Low PO2.
Yeah, low PO2. Below 10.3. Is that right?
Yeah.
Okay. Till 8. If it's 8, it's type 1 respiratory failure, it's CPAP, it's not oxygen. Right? Okay. If the patient is you happy with the oxygen masks and all of that?
Absolutely.
Good. So if the patient is in a way not very stable, they are grappling with anxiety, with breathlessness, which kind of oxygen mask would you prefer to start with?
Venturi.
Venturi, excellent. Well done. Everyone is happy with that?
Not a nasal cannula.
Not nasal cannula. I would start with something which is giving constant flow, because the patient is really struggling at the moment. Okay. So nasal cannula is usually used for something which is in a way controlled. And if for any reason you feel that the patient is in need for more support, you are just taking that out, putting the face mask, taking that out, and putting non-refusing face mask, and that's it. But the Venturi is usually used for some patients who are really struggling with their breathing. Okay, so it's a kind of constant flow.
Is that so? The amount of oxygen that they're getting isn't dependent on their respiratory rate and their tidal volume.
It's not the amount. It's the way of the flow. It's not the amount.
So yeah, because with a Venturi the flow is consistent.
Consistent, yeah.
Whereas with like a simple face mask, it's not.
Yeah, it's not. Yeah, it's fluctuating, so it's ups and downs. Yeah, yeah. Right. What else do you need to mention? Yeah, I think you know that with any flow rates more than 5, there should be absolutely not nasal cannula. Well, this is what I'm asking about. What I should be using on top of the oxygen, I mean, humidification. Yeah, that's it, right? So flow rates between 2 and 6 is nasal cannula, 5 to 10 is face mask, 10 to 15 non-rebreathing face mask. Venturi is a kind of different story. Everyone is happy with that?
Yeah.
Masks are there if you want to have a little play. Right. Think right now about the NIV. So, you happy guys with what is the meaning of those terms like IPAP, EPAP, all of that sort of things? Good. Okay. So the EPAP is the EPAP.
Oh, expert.
Yeah, but I mean, is it the minimum?
It's the minimum.
It's the minimum amount. So the IPAP is building on top of that. If the patient is having any spontaneous breathing, this is again building on top of the IPAP. Okay, everyone is happy with that? We have the device here if you want to see that.
I'll have a look.
We are expecting, again, in the assessment that we do some sort of interpretation for that.
So could this be on the exam?
That's why I'm saying, please come here.
So could we? But I thought we weren't supposed to know. No, we were not expected to say that. So in the exam, could we be presented with that screen and
Yes. Absolutely simple, don't worry. It's really simple.
So cool to see.
Just like 3 buttons, so it's not that hard. So first thing, whenever you are into first consideration with NIB, whenever you are introducing the mask, how you are introducing the mask. Can I get any volunteer with me, please? Oh, yeah, it's your jump in.
I'm about to ask the question.
Before taking down on your notes, what do you think ideally should be the way? Ideally should be the way of introducing that to yourself.
Trying it just against your face first, just to get a feel of what it's like.
Yeah, this is one of the things. Excellent. What next?
Explaining what it might feel like sticking your head out of the cup.
Yeah. But what about the straps? Yeah. Everyone's happy with that? This is what we should be doing. So I don't know. So that should be the way. And then you introduce that way. Okay. For the first day, we're not closing the whole circuit. For the first day. Okay. It's absolutely fine to see some leakage to be there. That should be alright. Ideally, the leakage should be. Yeah. Ideally, the leakage shouldn't be. Shouldn't be any more than what? What do you think?
40%.
40%. Excellent. That's it. It shouldn't be any more than 40%. Right. So this is the IPAP. This is the inspiratory part. This is the EPAP. Okay. This is the the backup. Like anything on top of that. So as you see, it's getting up to the level of the IPAP, getting down just to the EPAP because this is the one which is This is the one which is maintaining the airways open. If you take any deep breaths on top of that, what's that? Yeah, this is on top of the IPAP because it's a kind of spontaneous breathing, and this might be pushing the IPAP a little bit higher. So right now it's set at 16. Can you see that? So it's 16. If you are adding any breath on top of that, like spontaneous breathing, that means that you are pushing the IPAP a little bit forward. Happy? Right? Would like to try? Would like to see it?
I'd like to try it, please.
Yeah. Sure. So during the inspiration phase, when you press, it's slightly higher than the number which is there. You know what I mean? Yeah. This is like kind of spontaneous breathing. This is the normal breathing for the mask, I think you know that. Venturi.
Yeah.
Not breathing.
That Venturi,
Yeah. Yeah, that would be good.
The COPD case, because he's in type 2 respiratory failure. So I think it'd be better.
That's all.
Go on. When you press, it should be getting off because
Yeah,
it's
because
set right
he's
now at
already on
16.
the ventilator.
This is why spontaneous breathing is on top of that.
So the next
Meaning
step
that the patient is able right now to breathe.
So it's the increase in the IPAP with spontaneous breath.
You also sit down and
No, it's just because like as a physio, you would never expect him to set this
Yeah.
up. So why are you
respiratory. We're not
So you wouldn't be able to, you wouldn't be asked to set it up. You'd be asked to monitor it.
So he wasn't very clear with that.
Yeah, the inscription.
Like you wouldn't be asked to like describe
Yeah, like how
like
much.
the iPad that the doctors want to set that up. Or your band
Oh no, we
The
wouldn't.
most they can do is ask you to recognize where to put an item to set to. Maybe reason why.
Yeah, that's fine.
So this backup is in a way the spontaneous breathing.
Yeah.
So right, the patient is having 15 breaths per minute in case they need any more extra. Right, so
Nobody else actually
if you
says
see, let's say during the inspiration, if you take extra breath, that's not going to happen with the
Everything, yeah.
They are having backups of 15 for that. Right? So this is the maximum that they can do on top of the 16. Right? You get what I mean?
Yeah.